Okay, Nicholas,
Um,
did you kind of do that HIPAA prologue?
no.
I have not, no.
Oh, just so everyone knows this, one of the things we like to tell everyone is this will be recorded and be put on Facebook. So if you are sharing any personal health information, um, it will be it will be recorded and put on Facebook. So if you would like to either take yourself off camera, or if you would like to not use your child's real name, feel free to change that around or anonymize yourself as much as you feel comfortable.
So welcome everybody. My name is Emily Levine, and I'm Executive Director of the Autism Society of Southeastern Wisconsin. And the person who just did the intro is Brian Kaspar from Gemiini, and they're sponsoring this series, which we really appreciate. And tonight we're going to be talking about picky eating and how we can help people that have food intolerances or food challenges to have a healthier and more varied repertoire of things that they will eat. So our speaker tonight is Jordan Beck. Jordan is a speech language pathologist and a communication and feeding specialist. She's in private practice currently in Wauwatosa, Wisconsin. Jordan, do you want to take it from there and tell us a little bit more about yourself?
Sure, yeah. I originally started, I have worked with kids with autism before I worked with feeding patients. Working with kids with autism was definitely one of my passion areas in the beginning. I did multiple intensive trainings with the group out of Madison, Imagine a Child's Capacity, if anybody's familiar with them. I really highly recommend that organization, and they do some really fabulous trainings for professionals. And I think there was definitely parents there as well. And she had a really severe profound feeding disorder, and that's how I kind of got into this. We took her to different specialists and different therapists, and nobody could really figure out what was going on, and she wasn't getting better. And so they said you need to prepare yourself to put her on a G tube. And I thought, well, I can try to find somebody who is has some training in this, or I can go get trained myself. And that's how I got into this. So I really, really love working with kids with autism. They're actually some of my absolute favorites. I wish I got to do it more, just because I think the potential for these kids is so much. And when you can, really reach them and connect with them, it's just like one of the most rewarding populations to work with. So I won't talk too much about myself. Emily came up with really fantastic questions. And I love talking about all of this. And so I will try to save time for your questions afterwards, because they're such good questions. I could probably go on for 2 hours about all of them. But if there's things that are specific to you, let me know, or specific questions. But in the spirit of doing a talk related to autism, I do think all of us, myself included, we all like to know what's coming. And so, Emily, would you want to just read through the questions that we're going to go through? And that you came up with, that you felt like were a summary of things that you've heard over the years, and then we can just kind of start them one by one. And then at the end, I'll open it up to individual questions.
Sure. So one of the things that we hear frequently from parents is that they're worried or frustrated about their child only eating a very limited repertoire of food. And so part of the challenge is we want our kids to be healthy. We don't want them to be stigmatized because they won't participate. And when you think about how much food is involved in all of our celebrations and family get-togethers, it can be anxiety provoking for the whole family. So over the years, I've heard lots and lots of stories, and I've kind of chosen some common themes, and we narrowed it down to 5 questions that we're going to have a conversation about. The first one was, our dinner table is a battle. My child will not stay in the chair. I want us all to sit down together for 1 meal a day, no electronics at the table. How can I make them sit and be good? And then the next question is, this parent I have a 1-bite rule to get children to try new things, but my child gags on meat, chicken or pork chop, for example. How can I stop them from gagging and throwing up? Will they be okay if they don't eat meat? Another question, my child crams food into his mouth and doesn't chew or swallow until he chokes, unless he's prompted verbally to chew. How do we get him to slow down? Another question is, my child will only eat chicken nuggets, yogurt, and apple juice. Will they starve? And then we all frequently get questions about special diets. Do you recommend any dietary restrictions? Have you seen benefits from gluten-free or dairy-free or other special diets? So that's kind of what we started out.
Questions, yeah, they're so good.
Probably over the years, that's like one of those 5 questions will come up.
Yeah, we were collaborating before this, and Emily read those to me, and I was like, check, we're done. That's all we need to plan. Okay, so going to the first one.
Emily, I just had one quick question. Are we supposed to be sharing a presentation right now? I got kicked and then came back.
No, we're not.
Okay.
We have a conversation.
I'm sorry. Thank you.
Okay, so the battle at the dinner table. So this is usually when I get an intake phone call, this is the first thing that I hear. And I think this is a perfect example of we've heard it so many times, every behavior serves a function. And so if kids have the skills to do something and it's comfortable for them, they will do it. And I think it also really depends on the function of your child. And where they are on the spectrum. And so, how regulated is the child in general? How long can they sit and attend to a task in general? Is sitting and doing, are they able to sit and do a non-preferred task? So the thing about eating is for our kids, and not just my kids on the autism spectrum, but for all of the kids that I treat, it's very, very, very difficult for them. And I think we all can empathize with if something was really hard and we wouldn't be, and if food was really hard for us and it didn't bring us joy, and it in fact caused our body to feel like it was in danger or is in pain, or we were going to gag, or we were going to throw up, or it was a really offensive smell to our sensory systems, asking a child to sit there would not be realistic. And I always go back to, sometimes we expect things out of our kids that we wouldn't do ourselves. And so if it's something that is extremely hard to them, or it's really aversive to their sensory system, that's not a realistic expectation. So we need to look at what needs are not being met. And this is where a really good occupational therapist can be helpful. It's many times where we have a patient call the clinic, and we will give them some guidelines and some things some skills that they can work on with ABA therapists before they do come to feeding therapy. So some, basic following directions, basic sensory regulation issues, having a sensory diet in place before we get them to the table to start feeding therapy. Another big thing that we want to look at is the child's seating and positioning. And again, this is, a very skilled feeding therapist should be able to give solid guidelines and recommendations on seating. But this is also where an occupational therapist can be really helpful. So the example that I always give in the clinic is how uncomfortable it would be to sit and eat an entire dinner if you were sitting at a high top table and like at a high bar stool and your feet didn't touch. The examples that I give for the moms is if you were 9 months pregnant and you were sitting at a high top bar stool and your feet didn't touch, and how, you know, like wiggly you would feel, and, you know, maybe your appetite would turn off. And so kids really need to be grounded in their chair. So we talk about the 90, 90, 90. So their hips need to be at 90 degrees, their knees need to be at 90 degrees, and their feet need to be at 90 degrees. But again, this is something that can be assessed by an occupational therapist to see if they need to be, you know, maybe some kids do better with a little movement, like a cushion underneath them. A lot of my kids do better if they're sitting on an exercise ball during the mealtime so they can give themselves some proprioceptive input. So that can be very helpful. I think a big thing too for my kids on the spectrum is really, really paying attention to the smells in the room and really paying attention to like what things visually look like. Vision is very, it's one of the first steps in eating that we all do. And so if we're looking at something and and our body doesn't recognize it as food and it's really aversive smell to us, that child is going to want to leave and they're going to want to escape. And continuously just encouraging them to come back without teaching them how to integrate those senses into their neurology is not going to be helpful. Another really, really important thing, and again, sometimes we have patients work on this at home even before they come in for feeding therapy, is building a routine. So everybody learns better in a routine, and everybody is less stressed when they know what's coming. So like the example of us reading the questions before. And so when the routine is set, children can develop their skills. All children can develop their skills more consistently when the routine is set. And what we do in feeding therapy at our clinic is we build a routine that also works on increasing the interaction with food. So, you know, maybe at the end of the meal, and again, this can take a long time to get there. Sometimes we have to build the skills, you know, individually. So, you know, maybe in the beginning, we're just doing the micro step of, you know, getting them to the table and doing a preferred activity, and then getting them up to a table and doing a non-preferred activity for longer and longer. And again, this is something that can be very helpful with a team approach. So the occupational therapist, the feeding therapist, and the ABA team working together to say, like, what are the micro steps? Because I've worked with children in the past where I said, like, okay, well, I want them to do this. And the ABA therapist said, wait. There is like 5 different skills that you need to break down before you can expect them to do that. So that's where the team collaboration approach is very, very helpful. Start expectations small and build gradually. I always say with my kids, whether we're working on feeding or anything else, I always say, you know, we can get these kids to do almost anything, but we can't get them to do everything at once. And so, like, looking at what the biggest priority is and what's the biggest barrier, and then targeting that, or what's the micro step that we need to start to get them there. And then always remember, I am always really, really cautious with my kids, especially who are really, really restrictive eaters, and I'm talking about the kiddos who eat like Oreos and milk, and that's it. We have to be very, very careful about how we make changes, because if for some of our kids, and it sounds extreme, but for some of our kids, you know, say they eat milk and Oreos, not broken, they have to be whole, and chicken nuggets. And then we take that and we put it in a different location, that food is not that same food to them. Or if we make a change to it, that food might not feel safe to them. And the last thing we would want is for them to drop one of the few foods that they do have. So we do need to really meet the child where they are, be very respectful of them, and keep in mind nutrition is the biggest goal. And so if the child is eating, we don't want to do anything that's going to jeopardize that. And so we need to make the changes very small with providing a lot of support. Coming back specifically to the technology issue, because that is a big one. And that's one that we hear a lot. So when the child is watching technology, their whole sensory system is focused on the technology. And so a lot of times they will just kind of mindlessly eat, if for lack of a better expression, because the technology is taking over their senses. And so it's almost like the food is being numbed, and it's a easier experience for them. So if that's how the child eats, we're not going to take that away in the beginning of therapy. What we're going to do is, through therapy, we're going to build their skills so that they have the skill set to be able to eat with enjoyment without technology. So the last thing that we're going to do is say, absolutely no technology. You have to cut that out right away, because that's not fair to the child, and that's not respecting their needs. Okay, number 2, we have a 1 bite rule to get my child to try new things. My child gags on meat, chicken, or pork chops, for example. How can I stop them from gagging and throwing up? And will they be okay if they don't eat meat? So if a child doesn't eat any meat, I would recommend talking with a pediatrician and getting a nutritionist on board. So because maybe that would be one of the first goals that we worked on, would be getting them some type of protein drink that we could gradually desensitize them to. As far as the gagging, that is something that I hear a lot, not just from my parents of children on the spectrum, but from a lot of the people that come into our clinic. And we all eat through various steps. So if you watch a child, if you watch a young child who is say like 6 months, and you give them a completely new food, especially if it looks very different and unrecognizable to them, you're going to see them, they're going to look at it, they're going to touch it with their fingers, they're going to see this is what they do to see what's going to happen in their mouth. They're going to go and smell it, and then maybe take a lick, and then slowly they're going to taste it. I always say, the example I give to parents is, the first time, I love raw oysters. The first time I ate a raw oyster, I didn't just go, woo, and taste it. But that's a lot of the times what we say to kids. We say, just taste it. And that can flood their system. And so if a child is gagging on anything new, they're not ready to meet that step. The first thing if it was something new, the first thing I maybe would just ask them, and if it's hard, I would just maybe ask them to look at it. Sometimes with kids on the spectrum, the first thing we do is we just get them to look at pictures of food, because that can be really hard. And we all know that our kids on the spectrum do so well with visuals. And then we gradually work up to real objects, maybe a real object in a container. So that kind of shows you how slowly we take it, depending on the aversive level of the child. So I'm more so gearing this conversation to kids that are severely averse to food and have a very limited food. So if anybody has questions for kids that are more on the, mildly picky, we can talk about that at the end too. So again, maybe we just want to get them to start by just like looking at a food, or maybe touching the food to like clean it up at the end of the meal, something where we can build it into the routine. The more we do that, the more that child is going to build brain connections and neural connections to work up the steps so that they get desensitized to this food, and it's not so new and it's not so scary. So again, I give this example to all of my families, because the one thing that I feel like we've all heard, for decades and decades, is like, kids won't starve, which is completely not true. Kids won't starve themselves. If you just give them what everybody else is eating, that they won't starve themselves. And it's absolutely not true. If that was true, kids wouldn't be on G-tubes, kids wouldn't be failure to thrive. The analogy that I always give in the clinic is if I was starving and I hadn't eaten in 2 days, and somebody put a leather boot on my dinner plate and said, well, if you're hungry, you'll eat it, I wouldn't eat it because my brain is not registering that as food. So we have to keep in mind is kids aren't faking this. They're not manipulating us. This is hard for them. And when it's not hard for them, they do it. I mean, yeah, we do treat a lot of teenagers, and, that's a different story where there gets to be like some rigidity and, anxiety about things. But in general, if kids have the skills to do things, they will do it. Another analogy that I give with this is kids have kind of like an internal stoplight for food. And their brain either says green light, go, yellow light, like, oh, that might be interesting, and red light, stop. That's danger. That's not food. I feel like that is going to kill me. And what the kids that I see are usually green light, red light kids. They don't have any of the yellow where they go, oh, that looks interesting. They see it and they say, that is not my green light food, that I do not recognize that. I cannot eat that. I cannot put that in my mouth. I don't want to touch it. I don't want to look at it. Kids on the autism spectrum can also be very, very rigid in those differences where it can be like, I only eat Cheerios that come out of the yellow box, but I don't eat them if they come out of the pink box, like, or like if they're a different name brand. So that's where that, for the Jill, who has a 25-month-old grandson, as much as everybody can do this, trying to not let these kids see packaging is very, very important. And it can, it can be really hard and it can be inconvenient, but the more we can take that visual packaging up, because the packaging becomes a cue of that's a green light food. And so we can, like even, and the great tip that anybody can, try to do is if you want to, so I don't want to make changes to their favorite foods. I want to maybe make, there's a great book out there called Food Chaining, and and I think you wouldn't really need to. I mean, I can put a handout up on my website or something like that, or email it afterwards, but or you can look it up. But I don't think it's necessarily like you have to go get this big book and read the whole thing, because it generally is not enough to like fix these types of situations. But food training is where you maybe take a food that they really like. So like they really, really like plain Cheerios. So maybe we would get them to like, play with Honey Nut Cheerios. So it's just slightly different. The other thing that can be great to do is if instead of us making a change to the food, they make a change to the food. So, and they may not eat it if they make the change to the food, but at least they know that like they made the change and you didn't ruin their favorite sandwich for the rest of their lives and they have to never eat it again, because we don't want that. Okay. And the other thing that I think is really important, because you cannot BS our kids on the spectrum, they are like always 10 steps ahead of us, is like do it in a functional way. Do you know what I mean? Like do it in a way that they're helping you, or they're helping with cooking, or they're helping clean it up. Because if you just ask them to, do something that's not fun, it's not enjoyable, and it doesn't make sense to them, like that's not gonna, they're gonna be like, why would you ask me to do that? You know how to do that. That's not, that's not realistic. So anything that you can do to get these kids start exploring foods tactily, if they can help with cooking, if they can help with serving, if they can, take some fruit and put it on a fruit kebab, that's the type of really fun stuff that everybody should be doing with their kids. And but then also going back to respecting the child and meeting them at their level and respecting their needs. If a child, if you put something in that, at the other side of the table, and or close to the proximity of the child, and they're doing this and they're turning away, you're flooding their system. But in therapy, what we do is we do it so fun that the kids can't like help but jump in and look at it and interact with it. Or we pair it with sensory activities or gross motor activities to down regulate their their sensory system, organize their sensory system so everything doesn't seem so intense to them. Okay. Okay, my child crams food into their mouth and doesn't chew and swallow. And sometimes there can be gagging or choking. They do it unless they're prompt. How can we slow them down? So if it's a safety issue and the child is actually choking, that would be something that needs to be discussed with the pediatrician right away. If the child's ever had a traumatic choking incident, I would recommend talking to us or talking to Children's Hospital about how to modify the food and maybe, rationing out the food so that they aren't just shoveling it in and stuffing. Stuffing is generally related to three things. It's generally related to either sensory awareness, learned skills, or their awareness in their mouth, or oral motor dysfunction. So when I say oral motor dysfunction, the majority of the children that I see in the clinic, when I do an oral motor assessment, I find some type of reflexive muscular response in their mouth that's not working. And whether it's, a use it or lose it, where they just, because I have seen that before where the kids did have typical oral motor skills, but then they just, didn't really use their mouth properly for several years and didn't really chew their food. And then they actually did start to decrease their oral motor skills. Where like I assessed them in the beginning and they were fine, and then I assessed them later on and they weren't fine. This was actually for a patient that I didn't see for feeding. I saw him for other things. And then his mom said this stuffing issue came up, and I said, I know I checked his oral motor in the beginning of the assessment, and sure enough, when we checked it like several years later, and it was just because he wasn't functionally using his mouth, he was just kind of stuffing things. And okay, so that would be maybe where it's more of like a learned skill, where the child hasn't been using their muscles properly for several years, and so they don't reflexively do them anymore. Sensory awareness. So our senses come, especially children who have sensory processing disorder, our children on the autism spectrum. Sensory information either comes in too big, too small, disordered, or delayed. And so you can see how all of those would be related to stuffing, because what I see my kids doing is they put it in their mouth and they don't get that quick sensory response that any of us would get. And so what do? They keep on putting more and more and more. The other thing that's really abstract thinking, we can be overregulated and underregulated in the same system at the same time. So people will say like, gosh, well, there's such a selective eater and they really want only bland foods. Like, it seems like they're really averse to strong flavors. Like why are they so needing so much input for textures? But, it's something that we, as people with, relatively normal neurology, sensory systems, we can't, sometimes always put that into our perspectives. So that is something where I see where if they feel like they are going to, if it doesn't register them, or if the register of the oral seeking is very calming to them, they will stuff. So it's a sensory issue, it's a learned behavior from not using their mouth for very long, or it's an oral motor disorder, which is the oral motor is the easiest out of all of the things. They're all very easily treated, but the oral motor issue is the easiest to be treated. So what I would say as far as fading the prompts is, if you can't fade the prompt, then one of those three things probably hasn't been addressed. And maybe they need a sensory oral program, or like a daily, like an oral motor toolbox where they get to go and explore things that feel good to their body, or, on a set schedule, they build that into their sensory diet, because sensory oral motor is very, very important for these kiddos. So my guess is people might have questions about that one, so we can come back to that one for sure, because that's very, very common. My kid only eats chicken nuggets, yogurt, and apple juice. Will they starve? So this is a really difficult question to ask. And I always like to say, I'm not an MD, I'm not a dietitian. So, but from my anecdotal personal experience, what I would say is I see kids that grow like weeds on very, very limited food repertoires. And it's shocking so if they're genetically, if they have good genetics for growth and both parents are really tall, sometimes they can just grow, and it's a surprise to me, because I also see it go the other way, where sometimes kids are just tiny and they eat quite a bit, but they don't have great variety. So where I do see that sometimes start to trip them up is maybe they've been coasting and they kind of eat their snacky foods and they eat their 5 foods. Where I start to see sometimes they start to drop off on either weight or their micronutrients, and I'll come back to that, starts to get low, is when they get ready to start puberty. So about like 9, 10, 11 is sometimes where they just can't maintain it anymore. And so kids are resilient. A lot of times they can grow, but what I feel like the bigger question is, how do they feel on just those few snacky processed foods? And I don't mean to generalize. I'm just kind of speaking in, I'm just kind of speaking in, what we see most often. And so I don't want to say that to, when I say like snacky processed food, that's easier to our sensory system. And so that's what we see. I've had plenty of kids that have very, very low food repertoires where they maybe only eat 4 or 5 things, but it's all, really whole, nutritious foods. And so that, that can be the case too, but we still want to get them variety because of the things that Emily talked about in the beginning about how, food is how we connect with people. It's how we participate in society. It can be hugely anxiety causing for the rest of the family members. So then going back again, I have to give my disclaimer. I'm not an MD, so I cannot give recommendations based on, vitamins or anything like that. But if kids have a really limited diet, I do recommend that you talk to their pediatrician about doing a blood panel. Things that I see kids be low in and can affect how they feel is zinc, magnesium. A lot of us are low in magnesium, iron, B12. B12 foods are really hard. Like not a lot of like not picky kids eat B12 foods. It's things like liver and salmon and sardines and oysters, like all things I really love, but a lot of kids don't eat those things. So B12 can be difficult to get. And vitamin D, like all of us in this, area of the country are kind of low on vitamin D, but it can make us feel really, really crummy when we're not doing those things. I always tell my kids, the reason why we want you to get more whole foods and more variety is because, you might be able to fill up on your Cheez-Its or, your chicken nuggets, but you maybe would feel a lot better. So in the clinic, I eat with the kids, and if I have a lot of back-to-back patients that mostly eat Cheez-Its, and we have to kind of start there, and I'm eating Cheez-Its all day, I will tell you I'm not hungry at the end of the day, but I also feel really yucky and run down. And so I do get concerned about how the kids are feeling with the lack of nutrition. So sometimes, working with the pediatrician to get some supplements going, working with maybe like a protein replacement drink, like a Boost or something like that, can be really helpful for these kids and can make them feel better. Okay, so, okay, specialty diets. Do you recommend any specialty diets, and have you seen a benefit from gluten-free or casein-free? So again, this one is one that I feel like I have a natural bias towards because I have 2 kids. They're not on the spectrum, but I have 2 kids that have both have a severe dairy intolerance, and one has a severe wheat intolerance. Not celiacs, but a severe wheat intolerance. And so I've learned so much through that. And again, this is completely anecdotal through my own personal experience. When my youngest daughter, we actually figured out she had a wheat intolerance at 6 months when we introduced like the Gerber oatmeal, and she stopped sleeping. But as she got older, we could tell when she had been getting accidental doses. So because her behaviors were so explosive. For a child who's like generally pretty happy and dysregulated, she would have the most explosive, like could have gotten a diagnosis for the behaviors that she would have. And we would say like, she's getting it somewhere, but we don't know. And then we would find out a couple of weeks later, like, oh, they changed the ingredients on that brand of cereal, or this brand puts wheat in theirs, or like all these chicken salad was like a favorite at our house, and they put wheat in all these chicken salad. Who does that? So I just feel like with our kids, I'll come back to that. But so, when I talked, she sees a really phenomenal GI doctor. She sees Dr. Rivera at GI Associates. I cannot plug that clinic enough. They're amazing. And I said, because I was like, we were sure that she had celiacs because she was so sick when we did the wheat trial, and she didn't. And I said, this is her only symptom is that she gets explosive behaviors and she gets like shooting joint pains. And she was like, a lot of the kids that I see with like food intolerances, their only symptom is behavior issues. And so, I remember in those moments as a parent and as a SLP thinking like, gosh, I can see how parents say my child with autism had a 180 in their behavior when we took them off something. So going, on the other side of that, I don't think that you should take anything out of a child's diet just like without the support of people who work with this. And so for a couple of reasons. One, it can be really overwhelming to put your child on, the true way to do it is to take them on, like to do an elimination diet and take them off everything, and then gradually reintroduce one thing at a time and track their behaviors. And so, so that is, that can be really overwhelming, especially if it's like cold and flu season. Like, did they react, do they have a stuffy nose from dairy, or do they have a stuffy nose from, do they have a stuffy nose from dairy, or do they have stuffy nose because, they have a stuffy nose? And so that's why it can be really helpful to work with a team. The other thing is, a lot of times these kids, they don't have the repertoire to start taking things out of their diet. And so that's why I don't really recommend like a blanketed dairy-free, gluten-free diet unless you're working with a professional. And there are doctors who just specialize in this. I don't know if we have any in the Wisconsin-Milwaukee area, but there are doctors who just specialize in diet and GI issues just for kids with autism. And so that's my personal opinion, is working with somebody. And again, this is anecdotal, but I do find in general, my families that get the better results when they are looking at eliminating things out of a child's diet are when they work with more of a functional medicine doctor. That's where these people can be really, really helpful. If people want to, connect with me and get recommendations for the people that I've worked with that I've found helpful, but you want to work with somebody that's going to kind of take things out systematically. Now, if your kid really does a lot of variety things pretty well, and they'll do any brand of chicken nugget and any brand of bread, and you don't feel like they're going to stop eating if you change their preferred foods, then I would talk to their pediatrician about it and try it, and just be really systematic about it. And you could start with just the gluten and the casein, because those are two of the biggest culprits. Just
Jordan,
a side note, yeah.
Sorry, if I could just click in. I have
Yeah.
2 twins who are in their 20s. Both of them were highly sensitive to gluten and casein. My wife did kind of as much of a control as you can, but it's very difficult. We learned then
Stressful.
that McDonald's fries were gluten-free, casein-free. Fritos are gluten-free, casein-free. I mean, you learn all the things.
Oreos are casein-free, yeah.
Yeah. So, but one of the things I did is I posted in the chat, the NIH has an abstract, a meta study on
Awesome.
gluten-free. What they said was that there are some trials that show that it's helpful, but none are randomized control and big enough to come to a conclusion. But there's one that's, I put 2 links in here from the National Institute of Health.
Thank you. I'm gonna copy those and save those for myself. But yeah, so I do really feel like it's worth investigating. So yeah, I feel like it's worth investigating, and but it should be done a certain way. And sometimes if a child is really, really restrictive, we need to do it in a way that it's not, because again, if a child eats like one brand of chicken nuggets and then we make a change to that chicken nugget, sometimes they won't go back to eating that chicken nugget again. And that can be scary. So we have to, it really is an individual situation.
Yeah, one of our children, he only wanted to eat rice and ground beef, and that's what his meal was almost every single day. He had rice and beef, and
which is like, you can get by in, right? If you could add some beans in there, like
that's what we did. We'd sprinkle stuff in, we'd sprinkle supplements in. But yeah, it was a little difficult. One thing, just if anybody does this, I know most of you would know it, but dairy-free does not mean egg-free. A lot of people confuse them because they're in the same section of the supermarket.
I always say chickens don't have nipples.
Right,
so.
exactly. Anyway, I'll go.
Thank you. Okay, so that was our 5 questions. I will do the best to answer any questions that you guys have. I always like to kind of say, like, I will do my best without actually like seeing and getting my hands on the child. So I try to speak in generalities, but I'm happy to answer any questions that you guys have. Or you can put them in the chat if you're, I feel like I sometimes prefer to put things in the chat.
I have a question for you, Jordan. This is Jill.
Hi.
My grandson is 25 months old and he likes crunchy stuff. Crunchy, loves his pouches. There's quite a good variety, but he knows the pouch.
Yes.
Like you were saying, I'm like, oh, so my daughter, maybe I could get her to hide it or cover it or something.
Oh my gosh, yeah, I know. We've had so many moms in the clinic like hiding them in their purses. And
yes.
Yeah. Okay, so what she could do is she could work with him to if he would be willing to start putting, like, taking a spoon and squirting a little bit on it and starting to gradually eat it off of a spoon. The tricky thing about pouches is, my little soapbox about pouches is, they, going back to the steps of eating that I was talking about, they put them in their mouth. They don't have to put them back here.
Yes.
Where we chew everything up.
Right.
Usually the first ingredients is applesauce, so they're really yummy, even though they say like kale and beet and amaranth and quinoa. Like the first ingredient's always applesauce. They taste like applesauce. Oh, hi, cutie. Hi. And also they're only using the front of their mouth, so they're really only getting that sensory input to the front of their mouth. So even if they could take like a chewy tube. Where's my chewy tube? These are some of my favorite things. Where I'll put them up on our website under our favorite things. I'm working on getting that. But these are some of our favorite things. The younger the child, the softer the texture you're gonna get. But getting kids to learn that, like, it's okay to put things back here. another little soapbox about stick-shaped toys is, so a lot of the kids that I see, kids on the spectrum and kids not on the spectrum, is they only chew their food with the front of their mouth. So a lot of times if you look at a child who's chewing like this, which is kind of what they think we look like if we chew with our mouth closed, is they think we're chewing with the front of our mouth. So in the mid 80s, when they did the choking campaign, they took away, like things that are little and chokeable and like strings, but they also took away stick-shaped toys, or, and they made it for 3 and up. And so what happened is feeding and oral motor referrals tripled that year. And because kids were no longer exploring that cure, and where do we eat? So a lot of times a child has never had any input to the back 2/3 of their mouth when you go to introduce puffs, whatever age you introduce those. And so what happens is the child gags and, chokes on it, and, they can even vomit because they have had no sensory exploration back there. So getting something like this, which is a safe non-food item that has different textures and different grades of resistance that the child can start exploring. And then what he could do is he could maybe, again, you have to take it at their, do lots of modeling and make it fun, but, maybe mom could have one and he could have one, or, you could do this with him, dip it in the pouch, his favorite flavor, and then dip it in there. And then, see if you can work the flavor back there.
He does really good with chewing. He loves macaroni and cheese. He'll take his veggie straws and he'll bite them, and he'll chew with his molars. He's pretty good at very good food. I kind of want him to try maybe Cheerios a little more instead of.
Yeah, you can get some good, the fortified cereals.
Yeah, he likes these cauliflower chips, and some of that stuff is so salty. He likes that, but I was like, oh God, we got to get something different than salt. One other really quick question I'll let other people answer is, she uses the Danimals probiotic yogurt, the liquid, like smoothies. Is the Boost a better choice?
So Boost are more like a meal replacement.
Yes. What you're talking about.
Again, yeah. So again, I actually don't love Boost, but for some of our kids, it's a necessity. If I had an option, and again, this is me, I do tend to be a little, food is thy medicine, just because my own family's history with reacting to food. But, if you can make your own supplement to Boost, I try to do that. One thing that we do know about Boost, and again, some kids, they have to do it. So I'm not going to take it away if the doctor recommends it. But the thing about Boost is it's really, really high in refined sugars. And that it can be kind of addicting to the body and the brain and the stomach. So we know the more sugar we eat, now I'm getting off on a food nutrition tangent, but we know the more sugar that we eat, the more bacteria we grow in our gut to eat sugar. So we can get a Candida bacteria overgrowth. But it also, the other thing that sugar does is it suppresses the appetite. And so, that's why, a lot of us, for sure, myself included, at the end of the meal, you kind of crave something sweet, and it tells our body okay, it's time to be done eating. So if they do a sweeter meal replacement, for kids that we need to get them growing, and we need to get maybe a protein powder in them, we have them do it for a bedtime snack. So giving them all of that really sugary stuff right before they go to bed, because it's not going to affect their appetite. And then also they save all of those, calories, because it's kind of the opposite of what an adult should do. If you didn't want to put weight on, your doctor would never say have a milkshake right before go to bed and rest and save all those calories.
Yeah, I got him to try mini wheats with me yesterday.
Oh, that's great. Oh, I bet he loved that with like the high crunchy texture. Yeah.
In the bag, and he kept putting it in my mouth. I take a bite, and then he took a bite. I'm like, yes. He tried something new, but
yeah. So sometimes what you just described is that's why modeling is so important, to sit down and eat with the kids and show them what you're doing. It's the same thing that like animals in nature do. Animals in nature don't eat something until they see their parent eat it. So like what he did was like, okay, it didn't kill grandma. I can eat it now. So I think that is great. And that's very like good, curious learning. So keep that up. At 25 months, the best thing that you can do is just make sure that like there's a lot of variety at the table. And if he's touching and smelling and putting things on and off of his plate, he could do really, really well just with those like micro exposures to things.
Yeah. Okay. Yeah, he goes in November 3rd for the testing, not the birth to 3, but he's actually going to be diagnosed. So.
Oh, okay. Well, good luck.
Oh, thank you. I need it, especially for my daughter.
It's a tough time, but it's especially a tough time to have a child on the spectrum right now.
Yeah. Okay. Thank you.
I have 2 questions.
Yeah.
So I have a child that is a very visual eater. So visual eater, yes.
Okay.
So if it doesn't look a certain way, or if it's changed in any way,
like if the Oreo is broken in half, it's no longer an Oreo.
We have overcome that.
Oh.
But yes, for a while we couldn't have anything broken in half. If like the cracker had to be whole. The challenge we have now is like with desire foods, right? Things that we know he likes. So I could get 2 chicken nuggets from the same bag, but if they look different, he will only eat the one that is appealing to him visually.
Yeah.
So it's hard to kind of get him to process some of that. The same thing with scrambled eggs. So we can make scrambled eggs. He won't eat eggs if they come from a dark yellow shell, but he will if they're white.
Yep.
Very particular with that. And then it becomes sometimes a battle to get him to eat foods that are from his desire foods, right? Because he's so particular visually on what he's seeing. So I'm more lenient with him on that. And I try to really work with him on at least just kind of letting him eat what he feels comfortable with without really pushing him. But my husband doesn't get that. And
yeah, it's hard
because it is the
so
food that
easy
he
for us.
eats.
Yeah.
So I think, how do we help distinguish, right? What you said, they're not playing us. They're not trying to take advantage of this. How do we kind of find ways to meet him? I don't enjoy having to really push him for eating because it creates a lot of anxiety in him, and I see that.
Yeah. And then you're creating neural pathways for anxiety and not for learning how to eat. Yep.
Correct. So I'm trying to kind of find out with some sort of a specific strategy that I could use to really help him become more flexible in understanding that this food is coming from the same and it will have the same effect, but he doesn't always feel safe.
So one thing that you could do, a starting point is the foods that he could, because you said he's 10, correct?
He's 10.
He's 10.
Yes.
Yep. Okay. So one thing that you could do is if you could get him used to him making changes to his food. So like using cookie cutters or, teaching him how to cut food so that he knows like, I took this and I cut it and I made it look different. And so like, and then the other thing is like social stories might be super helpful with that. So talking about like, even though, this chicken nugget doesn't look as good as this chicken nugget, it's still a chicken nugget. The other thing that I would avoid, because I don't think this would have an averse, you know, and again, this is, you know, without trialing and erring, is I wouldn't go in, and maybe you're not doing this, but I wouldn't go in and like find a better chicken nugget. Do you know what I mean? Because then that is reinforcing that pattern of like, okay, that is the better one. So, you know, he doesn't have to eat it. So, and another great, I will put it in the, you know what I'm going to do is I'm just kind of making a note of some of the things that I said that I would post. And then I'll maybe, is it okay, Emily, like if I pass some handouts on to you, or if I pass some links to some handouts? I'm gonna get all of you a handout that we created based on the teachings of Ellen Satter, and maybe like, you know, raise your hand or give a thumbs up if you're familiar with Ellen Satter's division of responsibilities, where it talks about like, you know, the parent's job is to decide what's to eat and when, but then it's the child's decision to decide how much they eat, if they eat it or not. So that could be a helpful conversation with your husband to kind of like take the pressure off of it. It's like, it's okay that, you know, like he's not doing that because that's still hard for him and we can work with him for that. But if we push it and we say like, you know, if we try to like, you know, if only we could bribe kids to eat, like you know, like my job would be so easy if we could bribe kids or give them rewards or give them time out or consequences, or, you know, like if that worked, I would not have a practice because, you know, everybody would figure that out. So, and that's when you know that it's truly the child doesn't have the ability, is when you can't go like, finish this and then you can have dessert. Does that help answer your question a little bit?
It does. I'm curious
Yeah.
to see what you're gonna share, because I think that's the model. I mean, I do worry about whether he's getting enough, but I'm also realizing that it's just him overcoming some of that you know, that sort of tolerance. And so
Yeah.
I'm not worried that he won't eat it the next time. I think sometimes the frustration is okay, are we wasting food?
Yeah.
Right. So
Yeah.
because the rest of us
Especially
don't eat
now.
chicken nuggets.
Yeah.
The
right?
dog
Yeah.
the dog is happy, because I think the dog is just happy that he's getting the leftovers. She's getting the leftovers, but
Yeah.
I think it's kind of just coming down to that, and so I think that can create some frustration.
Yeah.
But
Yeah.
he
And
enjoys cooking.
he drives cooking?
So he's a baker. He can cook. He can make his own food, but
Yeah.
also the things that he bakes, he does not eat.
Yeah. Oh,
So
get him on Pinterest. And if he's visual, get him on Pinterest. Like,
oh yeah.
yeah.
It's just kind of
That's
getting
great.
him to the next step, you know.
Yeah.
So yeah.
Well, it sounds like you guys overcame the Oreo thing, and that's not easy to do. So it's, you know, it sounds like,
Yes.
you know, you have some strategies that are effective, and it sounds like you know them pretty well. So
Thanks.
yeah. Did anybody else have any questions about the stuffing or the oral motor issues or anything like that, or
Actually,
I can't remember which one I said we're probably going to want to come back to that.
I do. So my kiddo does not want any other chewy toys anymore, and we have overcome a lot of low muscle tone in the mouth. Breastfeeding was hard for him, and then you could tell, like, for a long time when he was younger, part of his mouth would drop a little bit, and he has overcome a lot of that, but you can still tell that he needs a lot of support still. And I don't know what else I could offer him to really do that, because he does not enjoy having chewy toys.
Yeah, that's actually that can be I do get that with some of my older ones, where they put everything in their mouth, and we offer them a chewy tube and they'll put anything in their mouth except for the chewy tube. So is there any type of like chewy food that he enjoys? Like, you know, like we literally go through Sour Patch Kids by like the 5-pound bag in the clinic because kids, it's so organizing to their systems. And so I do, if I'm being honest, I take out the red dye ones because I'm kind of a weirdo about, I don't really like kids to have red dye. So the grown-ups eat the red dye ones in the clinic, but like Sour Patch, like beef jerky, anything that's really like a stick-shaped food or really chewy, like, you know, somebody was mentioning the veggie straws before. Veggie straws are like great for oral coordination. Like that's what we're looking for. And they give you a nice, those big pretzel rods. I don't know if he does gluten, but those like the big ones where it's like really, really crunches in your mouth, those can be good.
Yeah, you know what I just noticed? I wonder if he does that on purpose. He actually eats fruit snacks, but he eats them the entire bag at once.
Yeah.
And then he just shoves them all in his
that
mouth.
Could also be like a 10-year-old boy too.
It could be. But
yeah.
Is that enough to actually get enough input though? Because I don't know.
Probably not. Yeah, probably
okay.
not. Yeah.
So I have to look for something a little harder.
So how you know that it's enough is if it kind of like, I mean, I shouldn't say that. Like that might be enough in the moment, but then if he's like continuously seeking it. So like actually literally today, I was working with a child who we do like in therapy, we do like a towel, like oral motor sensory prep routine with our kids. And this little guy, like, oh my gosh, he was chewing on his towel like he was like a new puppy. And I mean, he was just getting so revved up about it. And, you know, his mom finally took it away. And then I started on his shirt and she, you know, asked him not to do that. And then he started on her shirt. So, you know, I always say the analogy to that is like, if a really, really, you know, we all have different sensory systems. Like I do not like a deep tissue Swedish massage. Like that would like, I'm a total wimp about stuff like that. But if you really liked that and you really needed that and somebody just gave you like a really nice relaxing massage, like they could do that all day long and it would never feed that system. And so when I see kids that they're doing the oral seeking all day long, we're not giving them enough input. And that's when we do things like, you know, the chewy tubes or, you know, depending on, and again, like, I hesitate to recommend too many things because I don't want to recommend something that's like a choking hazard, but kids that have had their oral motor assessed and they do have good oral motor skills, like the sour atomic warheads, or like, you know, those, what are they, you know, those like fireballs are great. Things that are like really, really intense. I do really like those like big pretzel rods, beef jerky. Oh, you know what's great? And that gives all of that great input and big intense flavor is at Trader Joe's. They have they have them so many places now, like the dehydrated mango. They're like leather and they're really, really chewy. And now they make like the new trend is spicy ones. So like and a lot of our kids aren't into spicy, but if they really, really are seeking that, they might really like that. Or like, you know, Flamin' Cheetos or, you know, something like that, something really, really intense. Or, you know, another great thing is vibration. So a vibrating toothbrush, that can be helpful too.
If you want affirmation that Sour Patch Kids are liked by this age, and the dried mangoes, it's this guy right here loves them.
I see your dimples showing. That's what we say in my house. I see your dimples showing. Yeah, they're great. They're great.
Thank you.
Maybe he'll have to try the spicy ones next.
He doesn't like spicy.
All right. Anybody else?
Well, thank you, Jordan, so much. I think this was very helpful.
Yeah, I'm glad. Thanks for having me. I was just looking forward to this all week. I could talk about this stuff all day long.
Jordan, I have one more quick question. he has those swaddle blankets, those thin and he gnaws on it, and he's getting holes in a couple of them. And now he's got 2 of them that he takes all over. And I try and hide one away, so he just has one, and he'll bounce on his little tiny tight trampoline. And of course, he's got that in his mouth. And we know when he's really hungry as he stuffs some more of it in. Would the Chewy toy help to get the blankie? Why? I know it's a sensory issue. It's not a taste issue.
Yeah, and it's also calming. You think about, like, almost all of us are calmed by, whether we realize it or not.
Yes. Yeah, he'll just sit there and then he'll chew on
it. Babies, they, a lot of babies, they can't calm unless they have a pacifier. And, and the jumping. I would maybe see that. I think it's great that he's chewing on that and he's using his trampoline. I would see that as a sign, and you're kind of just in the beginning of this journey. So I would really look into sensory processing, and what he's trying to do is he's trying to regulate his sensory system, and it sounds like he's seeking what he needs in a functional way. But a lot of times it means that they need more sensory regulation and an actual, like, prescribed sensory diet, and an occupational therapist who is really, really skilled at sensory. So not all occupational therapists do sensory. We're lucky in that I'm in the Milwaukee area, and we have quite a few great ones that and especially over the past couple of years, there's some really good ones at Children's Hospital now. There's Wauwatosa Therapies. I don't know where you guys are, but Wauwatosa Therapies, and Carol Wingenter, she's phenomenal. But I really can't say enough. I really, really strongly believe children on the spectrum should be seeing an occupational therapist that is going to give them that's going to give them a sensory diet and help them regulate their sensory system, not just for eating, but for just survival. When our sensory system is not regulated, that is a lower level, that's like a lower level brain skill. And it's really hard to develop our other skills and participate when our sensory system is in chaos. And I'm a strong believer that is like the primary disability of children with autism. And when you get those kids regulated, they blossom. Okay.
I'm just trying to grab as much information as I can right now. I bought him, a little tiny text trampoline. Oh,
that's awesome.
God. It is just wonderful. Instead of bouncing and jumping on the floor, and he's a tiptoeer too, I'm like, get him a trampoline. And I was going to save it for Christmas, but I just gave it to him.
Oh, I love that. Yeah. I know, I was turning around to see if my kids' trampoline, my youngest is 8, and we literally just got rid of the trampoline, because sometimes I would be like, oh, go jump on the trampoline, go regulate yourself.
Yeah. Okay. All right. Well, thank you again.
Yeah. It's really lovely meeting all of you and enjoying this night with you.
Okay.
Any other questions before I take off? Great.
Thanks, Jordan. I really appreciate your time.
Yeah, absolutely.
Okay, good night, everybody. Thanks for joining us.
Good night.
Good night. Thanks. Bye-bye, everybody.
Bye-bye.